Hello to those of you who are joining. Nice to see you all back. Some of you are returning. Glad to see you. Let's give another minute for everybody to hop in out of the waiting room here. All right, well, thank you all for joining our TikTok webinar today. This is session 7 of 10. We are offering nursing contact hours for each of these 10 sessions. So as you can see the disclosure slide that I have pulled up here, these are also being recorded and they are available on our Mountain Pacific website. So the next session will be on February 24th, same time, 3 p.m. Mountain Daylight Time, and it'll be on psychopharmacology in nursing homes. There will be a few there'll be a few polling questions that we'll bring up during the webinar, as well as a link to the evaluation. It'll be placed in chat during the webinar. So if you are claiming nursing continuing education credits, one of the polling questions will be your credentials. I will need to know that so I know who to look for to send your nursing CE to. What else? Let's see, you'll have the ability to unmute yourself, but please keep yourself muted when the presenters are speaking, but you may sure come off mute if you have a question, comment, or anything like that. I know Dr. Reza really likes interaction from the participants. We also have time at the end for question and answers. So, but in addition to that, please enter your questions or comments into the chat box. And then after I introduce the speakers, I'll recap what was discussed in the last session, which was January 27th. And then we'll start with this week's topic of managing behavioral emergencies in nursing homes. So now I want to introduce our guest speakers. Dr. Eric Arzubi co-founded Frontier Psychiatry in 2019 to introduce an accelerated, more aggressive response to Montana's growing mental health crisis. He served as chair of psychiatry at the Billings Clinic for 5 years, during which time he led the creation of Montana's first psychiatry residency program and Montana's first empath unit for emergency psychiatric care. Before moving to Montana in 2013, Dr. Arzubi spent 10 years at the Yale School of Medicine, where he earned his MD and completed postgraduate training in general psychiatry and child-adolescent psychiatry. And our other speaker, Dr. Reza Gomi. Dr. Gomi holds a BS in computer engineering from Rensselaer Polytechnic Institute, an MSc in biomedical engineering from Johns Hopkins University, and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology such as voice recognition to track and monitor treatment of neuropsychiatric diseases, such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So thank you both, and I will turn it over to you.
Great. Thank you. Sharing screen. Dun, dun, dun. Okay. Nice. Okay, cool. So what are we doing today? Everyone be ready to contribute, okay? Don't make me come after you this time. The learning curve has been a little flat on this one, but we're gonna get some contributions. So this is part 7 today of our 10-part series. We are talking about managing behavioral emergencies. For those of you that joined us 2 weeks ago, we talked about preventing behavioral emergencies, but I wanted to split them out because I felt that it kind of required more time to really dive in. Also, we like to cover some of our previous topics for those of you that have not joined us before, but just to sort of also refresh, because I found that repetition is one of the better ways to learn. Nothing has changed during the course of these talks, so I still work with Frontier and BrainCheck. Just a little overview of where we are. So we're already at the 7th session, if you can believe it. We started this in November, and we're already in February. So now I know it's finally dumping snow all over Montana. So it was dry for a while, but now we get to sit inside and listen to this awesome talk. So we are going to review for a few slides what we've done to date. And what I want to do, for these next few, now that we've really seen a lot of this, and many of us have seen this before, who wants to, I want a few people to kind of jump in and just say kind of, what's your reasons for caring about trauma-informed care? A couple people, can you unmute yourself and share? Or if you're really shy, you can type it into the chat box. Anyone at all? There's no wrong answers here.
Hi, this is Julie, and I'm a social worker at a long-term care facility in Gillette, Wyoming. And I think the importance is not only regulatory, as I think that's probably where we're coming from, but I know, we work with residents every day who have trauma in their past. Some of the obvious ones, war veterans that we're seeing, domestic abuse survivors. I also like how some of our topics have really gone into some of the longer term things, childhood trauma, the ACEs presentation was fantastic several weeks ago. And I think, we can learn stuff because we have to for regulatory purposes, but I think, the engagement comes in from wanting to do best care for the residents. And that comes from a holistic approach that certainly includes knowing who they are and why they are the way they are.
Excellent. That's right. I mean, ultimately there are regulatory reasons, but really it seems to really, I hope for all of us, it makes sense. It resonates, and it really helps us actually. It's a win-win because the people we care for do better, and their outcomes are better, and it feels better to do it this way. So it's sort of a win-win. Anyone else wanted to say anything?
There are a few comments in chat too.
Oh yeah, and so I can see those. Thank you, Lona. Amount of younger residents being admitted to long-term care with trauma, also because of a lot of our older residents that have dementia have trauma we are not even aware of. Absolutely. Can be really hard sometimes with people with memory issues to necessarily bring it up. And so we've talked about in previous talks using caregivers or family members, anyone that's known them a long time, to try to learn some of that. So it helps our care.
I am newer to the group. I am from Alaska, and I work for the Long-Term Care Ombudsman's office, which I'm actually newer to that office, but formerly I've worked in long-term care for many years, and I kind of saw firsthand a issue with a lady who had been discharged from a facility due to being combative, and the facility I was working in was able to work with her and really help her to thrive. She experienced dementia, and her issue really was actually because of childhood trauma and the way she was being approached with her care, and it wasn't an issue once she got with somebody that could treat her in the right way. And it was very inspiring to me. Trauma-informed care, I know, has been huge in some other areas with mental health care, but I haven't really seen as much in senior services and long-term care services. So I'm excited to see it come into this platform and learn more.
Great. Thank you for that. That's very interesting. And yeah, I love the anecdotes. So if you have stories like that, it's great to share with the group. And one thing I'm hearing there is, if something you're doing, whether it's because of just a personality mismatch or something you have no control over, maybe it's like the color of your hair. We have to always think there could be something triggering for a patient that has nothing to do with us. It's nothing personal. And, facilities, we need to step up and help each other and move staff around and find the appropriate fit. It's not always something you can personally, adjust for. So you have to have an open mind and really not taking it personally. A lot of facilities I've found, I've had a lot of patients through the years end up, with APS involved and things like that, all because of misunderstandings or inappropriate approaches, things that just weren't fitting. But, there was staff, and these are mostly in adult family homes. There's places with very, very little staff, but there's kind of a mismatch of culture or mismatch of just personality. And so it's unfortunate because that's not necessarily difficult to solve, but you got to be aware of that possibility to even be able to address it in the first place. Jill, you think you have control over the color of your hair, but I don't know. I clearly do not. So
I totally do have control.
You
Till my dying day, I'll have control.
Yeah. And then Judy's just commented one other comment: 1 in 5 kids in Montana are in poverty, which increases the risk of trauma. Absolutely. Suicide is number 4 in Montana, and more adolescents are committing suicide because of trauma. Trauma impacts health, and elderly people are high risk to complete suicide. Those are all absolutely correct statements. And so these were some of the things we talked about with the introduction to trauma-informed care. We went on to talk about our little case study where we just did a really introductory proof of concept of, can we just even start with some baby steps? A lot of this series is focused on, don't feel overwhelmed, just take one little thing you want to do or make a change and try it. And so we did a quality improvement study with the Montana Mental Health Nursing Care Facility, a wonderful facility in Lewistown, Montana. And we basically just started with some basics that were measurable. We're not the end all be all. It wasn't the ultimate, mark of success, but we were working with a patient population that was with severe illness and limited ability to participate in care. And so we were unfortunately having to take some freedom in terms of, deciding what to do, which is not ideal. But we wanted to respect patient autonomy. We wanted to reduce medications, things that we knew across the board are generally the right way to go. And so we did a little quality improvement study, and we were able to do that virtually with telepsychiatry, and overall it was a big success. We talked about loneliness in nursing homes. This is another key factor, and I hope you're starting to see too, all these TikToks are tied very closely together. So when we're talking about managing behavioral emergencies later today, very much everything else, these previous talks were all kind of leading up to this. Loneliness is something that wears away at us. It builds. It's something that is sort of adding up over time, but can be addressed at any moment too. And so we talked about how loneliness has direct impacts on your health, on our health, on our residents' health. And boy, during COVID, this is the hardest year for a nursing home resident probably ever in history. So a lot of us here listening have probably felt out of, like we didn't have control, or we kind of felt helpless at times. And so our goal was to look at what are some that may seem very small, but maybe some small steps that can still make a difference even during COVID, and encouraging interaction and relieving that sense of isolation. That graph in the lower right was demonstrating the fact that loneliness and isolation are as or more harmful as many of the dietary and smoking and other medical risk factors we usually spend a lot of time looking at. We don't usually spend as much time looking at loneliness, but it's deadly, especially for our older population, people with brain disease such as dementia or some kind of neurodegenerative memory loss. Loneliness absolutely is deadly. And we've seen one of the statistics we looked at was the much higher rates of death in our dementia population during COVID, not because of direct infection, but because of these other issues like loneliness. Down here on the bottom left, asking families to step up, or friends, anyone, to do video calls with residents, encouraging them to wear name tags. It's much more approachable, especially for those with memory loss that have trouble remembering names. Encouraging people to be creative with writing letters. It can be tempting to do a lot of phone calls, but that's not necessarily, it's good, but kind of encouraging creativity. It's easy to always pick up the phone. I call them every Tuesday. Well, hey, can you like come by and like stand outside, or write a letter, do something a little bit different. We talked about dementia, which is my area of specialty, and we wanted to bring some more awareness to just defining dementia and how it is diagnosed and found clinically, and how that helps us take care of our residents and patients in our long-term care facilities. And so one of the focus that we had was knowing that dementia is an umbrella term. It's not a biological diagnosis. It's not a specific diagnosis. It's a functional diagnosis. So it's telling you, when you know someone has dementia, you know right off the bat that they need help with 2 or more areas of their day-to-day functioning, like getting lost and paying the bills, or they're cooking. They can't really prepare food for themselves and they can't do their finances, something along those lines. It's not part of normal aging for a lot of cultures, including around the US, right? A lot of people, my grandparents had it, my parents had it. And dementia is not a normal part of aging. So it's not something people should be prepared for. We should be preventing it, but not necessarily expecting it. Alzheimer's is the most common form of dementia. So we hear that one the most, but turns out it's a very mixed bag. A lot of a previously diagnosed Alzheimer's turn out to be actually, when we look at autopsies, something different. So just keep in mind, the important thing is to know function, to know the individual patient, trauma-informed care, how to care for them. But medically, it's really going to benefit us to be as specific as possible. One thing I'd like to point out, we've gone over this a few times, is the normal aging, keeping in mind that there is some normal decrease in things like spatial orientation, which is why we all don't like driving. It just gets a little bit harder as we get older. Numeric ability, verbal ability, like those things should stay pretty much the same or get better with age. Speed, spatial awareness, those things become a little bit slower, but still not to a point, remember, that it would impair your functioning. Your function should not change, meaning I'm still going to the grocery store. It just takes me an hour instead of half an hour, but everything's fine. I'm still paying my bills. It just takes me a little longer. That's all normal. Or I'm forgetting some of my friends' names. Not a big deal until things are really getting messed up. Like they're forgetting people's names that they've known their whole life, things like that. Jump in with any questions, please, as we're going along. Another point I really like to really illustrate here is that dementia, we're able to diagnose earlier and earlier over time. This purple line on the right, that's been our traditional diagnosis point. So once dementia is already here, we do our clinical evaluation and we can say, okay, you have impairment in functioning, you don't have B12 deficiency, you don't have horribly uncontrolled diabetes or sleep apnea. We rule out all those other things and we say, okay, you have dementia and it's probably something that's neurodegenerative. But what's happening is with our technology and some biological markers we're finding, we're moving that curve to the left. So we're even able to detect dementia now before someone even shows symptoms. Now, of course, this is not standard. We shouldn't be screening everyone by any means, but we do have the ability. And so that's going to become more and more accessible. It also lets us diagnose someone very specifically. One thing I always, kind of like to bring up, like, why bother? Again, let me ask some of the audience to jump in here. Like, why do you think it matters? And if you actually, what would actually be helpful too is anybody on the call feel like it's still not convinced? Like, it's like, dementia's dementia, whatever. Trust me, I get this every day and it's not wrong. Jump in and tell me who's convinced, who's not convinced, and what are your reasons either way. Someone go ahead and jump in, pretty please. Someone new. I saw a couple people I recognize on the call, so don't make me call you out. Don says he's convinced as a TBI survivor. You mean convinced that convinced that it is important? Got it. Casey, are you able to talk? I see Casey from Wyoming on the call. Someone, I know some of you might not have microphones, but someone jump in. We're going to sit here. You guys know I'm all about awkward silence. No one's going to jump in. You guys are doing this to me.
Hi, I'll jump in. I'm Dana Mitchell, and I'm new to Mountain Pacific. I live up in Anchorage, Alaska, and I'll be working with Jill. And I think it's way important to father, because I've seen people live with dementia of various forms in the nursing home setting, and it's heartbreaking, and I wouldn't want that on any of my loved ones.
Thank you. And then, yep, Gail says she's seen instances of dementia with delusions, and this seems to be more common now than 20 years ago. Absolutely. Yeah, a lot of neuropsychiatric symptoms with dementia. That's the rule, not the exception. So that's absolutely right. We're going to see those things. Don says important for prognosis. Absolutely. Best careful where they are in their diagnosis. Absolutely. So really, yeah, these are great answers. And yeah, again, feel free to type into the chat if you don't have a microphone or otherwise, but there's no excuse for you guys. You got to type into the chat then. I'll accept that there's hardware issues, but I bet you have a keyboard. So yes, it's really important. Some of it, I've really learned over time how impactful it can be and beneficial to have a diagnosis that is as specific as possible. And even the diagnosis of dementia, a lot of patients are floating around with a memory loss in their chart, or no one's really sat down and had that, hey, I think this is neurodegenerative and this is why. That kind of conversation. It can really open up a lot of possibilities for people. No one likes having uncertainty. No one, and we don't want that when we go to the doctor. So we should really be doing our best. And that's the way I function, is I want to answer as many questions as I can for someone, even in times when I can't be as specific as I want. A couple other things just to point out: the Lancet Commission, this was redone just this past year. And so basically just pointing out, as we're all thinking of, well, we work in a long-term care facility, what are we going to do for our patients? Turns out quite a lot of dementia is thought to be reversible, 40% potentially modifiable. They revised this to increase that number. And you can see along the pathway from early life down, winding to later life, things like getting our patients to use their hearing aids, addressing any brain injuries they have. Of course, the usual hypertension, alcohol, obesity, especially when they have vascular aspects of their dementia, you can actually stop that part of it. Smoking, depression, social isolation. I mean, these add up to a lot. So this is very impactful. If you take care of 100 residents and at least 40 of them, you can have a really positive impact on. I mean, that's amazing for something that we historically have all thought, oh, wow, there's nothing much I can do. I also we've highlighted in previous talks the finger study. And so more attention to these preventable and modifiable risk factors. So the usual suspects are here. And then there's what they did in the finger study, which they actually took a large cohort, 1,260 people, they followed them for a couple of years, and they addressed some of these domains, including some cognitive training exercises. And you can see there was improvement that was sustained for up to 2 years even after. So it's great. Those are all really, really positive findings. We also touched on delirium, and again, this is very tied to our talk today with behavioral emergencies. So delirium is very much the source, or sometimes the cause, of behavior that we're kind of taken aback by, surprised by, and really have to think about some of the medical underlying comorbidities that might be causing it. So I threw up the criteria here. So patients that, it can be hard if at baseline they have some actions that are otherwise challenging or unclear. you have to really tease apart. Is this a sudden change? Is this a change from their baseline? Is there disturbance in attention and awareness? It's a kind of a quick change. Delirium usually develops, within a day or two. It's not something that's been building slowly. That's more under the dementia umbrella. They are cognitively impaired. So someone who normally knows where they are or what their name is or what time it is, that starts to be impaired. So that's a big problem. And, basically having trouble paying attention. So once you're seeing these things, these kind of veering away from their baseline, delirium becomes a big concern. And so what are the risk factors? Dementia is one of the biggest ones, really increases the risk of delirium. And think of that as, our brains, as they're breaking down because of dementia, just less able to process stimuli in our bodies or from environment that we otherwise can process. So if I have dementia and my brain is getting hurt and I have a urinary tract infection, am I going to be able to come out and say, oh, it hurts when I go to urinate and I'm uncomfortable? We might not be able to say that. So what will we do? Delirium happens. We get confused. We can't process the signal from my bladder, and it comes out as a whatever it might be. It's different for everybody, but it might be a delusion. It might be a hallucination. It might be anger. It might be laughter. I mean, that's the kind of the point is there's a jumble happening in the brain, and it's coming out the wrong way. So you always ask yourself, what might be causing this delirium? And look here, patients, we kind of are big fans of avoiding physical restraint. It's just sometimes, it's absolutely, but I found in practice, if we can exhaust all the other means, it almost never is necessary. Now, granted, I know some of you we have a wide variety of settings, and it very much depends on the setting. You might work somewhere where you're taking care of the sickest people, but just you keep in mind, and it motivates us to get those restraints off as fast as possible, even when they are used. But they're 5 times more likely to have delirium when they're restrained. So mobility is a big predictor of delirium. It's something we all see because it's ubiquitous in the nursing home care and the long-term care setting. So we have to be very comfortable with it. So delirium triggers, things to help also treat it. Similar things, which is interesting to helping with dementia, right? Let's keep the senses sharp. So we need to make sure people have their glasses on, their hearing aids in, that they can hopefully orient themselves with a clock or a calendar, things that let them know where they are, who they are, what time is it. Those are all basic things that then and that's for all of us, right? If you woke up somewhere, if you woke up tomorrow morning and you had no idea where you were and what time it was, you'd probably be a little bit agitated, right? And that's even without dementia. So now imagine somebody with dementia, what that's going to feel like. So use consistent staff as much as possible, label rooms, try to put pictures on their door to help them get back rather than expecting them to remember a room number. All these little things make a big difference. Redirection, and again, delirium is a big deal because those that resolve by 2 weeks, we're able to get to their pre-hospital function. That 2-week level is a big cutoff. If they don't kind of start going back to normal, we get really worried that this is not going to reverse. It is a medical emergency. So of course you want to involve medical staff and just say, hey, something's not right. And they might say, oh yeah, look, they have a urine infection. Oh wow, their chest x-ray is showing a pneumonia. Or, oh, wait a second, they're really dehydrated. For some reason, they just stopped drinking enough fluids. So anything can trigger it. Keep that in mind. Any change, they didn't sleep well the last couple nights, anything that kind of can make us think of it. If it's something that can make you feel uncomfortable, it can cause delirium. So if you're dehydrated, you didn't sleep well, you have an infection, it's anything that's hurting you is also going to do it. We talked about avoiding use of physical restraints, reorienting as much as possible. Interesting statistic down here with the clock or calendar or telephone in the room, big predictor of delirium or disruptive behavior. So that really helps people. And so sometimes we just have to kind of orient them or point that out, train them to use it. And just be kind of, warm and approachable, decaffeinated tea, helping them reorient to the sleeping at night, not sleeping during the day, helping them be comfortable and so on. So last time we started talking about behavioral emergencies. And so really the definition we talked about last time. Here, let's have someone else jump in and go over like what is your understanding of a behavioral emergency, and tell me what your understanding is. Yeah, and thank you, Jill. You said sometimes helpful to have a photo of the person when they were younger on the outside of their door. That's very, very helpful. Who wants to talk about behavioral emergency, whether in the chat or jump on audio, please?
I think it would be a sudden onset of uncontrollable behavior, whether it be striking out or just screaming out or something like that, but unusual.
Okay. Now, would you consider that behavior, let's say they struck out, or what if it's only just like kind of once for a couple seconds? Would you consider that a behavioral emergency?
No, it would be something you couldn't help them settle down and
okay.
stop.
So in your mind, you're thinking you're going through some steps here. You're trying to de-escalate, comfort them, and it's escalating and you're not able to.
Correct.
Okay, great. Yeah, at risk to harm to themselves or others, absolutely. So that's exactly right. We want to be careful about how we define behavioral emergency because it can be something different for all of us, right? We all have our own experiences. We all have our own comforts with agitation, and that's perfectly fine. It's all about the self-awareness. So let's say I'm someone that grew up around a lot of violence or a lot of, and I'm more comfortable. It doesn't bother me sometimes when people are yelling in my ear or striking out even. I'm like, oh, silly, don't do that. Whereas if I had been traumatized or just for other reasons, I mean, you don't have to be traumatized, but you have experiences. Otherwise, the second someone raises their voice might be very disturbing to you. So we want to be aware of how we react to those situations so that we're prepared. That's a big step of this, because in behavioral emergency, we want to be careful that it's when there's a danger, a true danger to themselves or somebody else, that if there is not intervention, there's a high risk for harm. So that's what we want to talk about. Now, many of you work in long-term care facilities as well as I do, and we see people that may be part of their daily routine. Some of it's more acceptable. We know how to redirect. And, so we're less likely to call that a behavioral emergency. But if we don't intervene, there may be harm, like they may walk out the door and disappear. So we want to kind of be careful. Here, we're really talking about, we want to focus on what do we practically do? Can we de-escalate? How do we do that? And how do we people with a trauma-informed care perspective? And just keep in mind that if you feel threatened, that's not wrong. It's also appropriate then to bring someone else or get feedback, because you might be aware of yourself and say, you know what, when someone with these characteristics comes at me that way, that's very triggering. So I'm going to bring in another staff member to kind of help me and help kind of balance things. That's perfectly appropriate. So you want to keep that in mind. We talked about prevention last time was really more the focus, which should always, of course, be the focus. We don't want to be in a position of having to manage it. And keep in mind, behavioral emergencies are largely preventable. If they happen, it's not a failure. They do happen, but there are things we can do to prevent them. And a lot of that is how we approach people. And so we talked a little bit about counterproductive measures. So there's a balance, there's a fine line depending on the patient and depending on, for example, dementia and the severity. There's a fine line between being validating and challenging it versus being redirecting and being invalidating. So when someone's talking about something emotional, of course, the right thing to do is be validating, listen empathetically. Now, what if you have someone who is older and later in the course of dementia, where their memory is really severely impaired? They're at a point where they're really not interacting with their environment very effectively. Maybe they keep talking about something traumatic from their past. At that point, when it's repetitive and it's not clearly, it's not helpful for them, that's when you can kind of make the decision, well, you know what? I'm not sure it's actually helpful for me to validate this. And we're not saying don't, invalidate it. What we're saying is you can redirect in that moment. And that generally helps, because sometimes talking about that kind of bad memory or whatever happened can raise agitation for that person, and they don't have the wherewithal at this point to have a conversation. So that's when we can redirect. So sometimes people will say, oh, I keep telling them it's not Monday, and they keep saying it's Monday. It's like, well, you know what? Is that really hurting anybody? You know, if you've told them a couple times and they're not able to register that, it's time to like move on, you know, let it go, and just kind of redirect and talk about something else. And for family, it's especially for family and caregivers, that can sometimes be a big sticking point, because, you know, it's so hard to look at your loved one and say, how can they not know it's Monday? And so they might be in pain. They might be really struggling with that. And so the right thing to do is to just say, hey, you know, this is nothing to do with you. If we could fix that, we absolutely would. But maybe better right now to approach just kind of change the subject, talk about something else. So a lot of that will help prevent, because those are the things that inadvertently escalate and become in a behavioral emergency down the road. So we can kind of stop those things before they start. Now, really avoiding issuing threats, that's just not really going to be helpful. Keep in mind, you know, you're caring for people that have limited independence. They're not necessarily there by choice. And so, you know, we're already in a position of power. We don't need to necessarily flex more power. I mean, it's pretty clear from, you know, a lot of the times the situation. None of us try to speak condescendingly. I know that. It just sometimes, again, keep in mind your audience. Depending on where the person's from, they might think it is. I've been told many times now at this point through my career, like, oh, you know, you have a tendency to speak with too many big words, or kind of feels condescending. Oh, thank you so much. And I kind of have to readjust. So open stance to feedback, you know, and that goes a long way. Let me actually, deceiving, you know, the whole hiding drugs, you know, that can be hard. Don't overpromise, of course. The hiding drugs is such a hard thing, because part of what I do is try to keep patients at home as long as possible. And that involves their family taking care of them. And so the family will say, oh, you know, they don't really want to take this, so I've been breaking it up and putting it in their applesauce. That's a really difficult ethical gray zone. And so that's for, you know, everyone to sort of individually map out with families. I don't think in a professional setting, a long-term care setting, that's the right thing to do, unless it's been fully, you know, discussed with family and, you know, the medical decision makers and the staff. And it's really what is kind of the safest way to approach. But I think that requires a conversation. I think we should hesitate and really think about it before we start doing that, because that really is touching on a patient's autonomy. And we always want to be, that's the most serious thing we have to consider when we're caring for someone. Just pointing out here, preventing behavioral emergencies. So keep in mind, you know, when we look at people across a large cohort with substance use disorder, the largest overlapping predictor of behavioral issues, behavioral emergencies, again, harm to themselves or others, dementia, delirium, epilepsy, cerebrovascular disease. So you can see these are all things that directly impact your brain's function. So anything that's going to hurt your brain is going to make it more likely that you might get agitated and just kind of be at risk to harming yourself or others. And so I got this good feedback the other week from one of our attendees here, and it was a really good point, is being mindful of using behavior as a term without context. Context is everything, right? And this person was nice enough to point out, you know, what if you're helping somebody, you know, go to the bathroom, a resident, and, you know, you all of a sudden you're starting to undress them and they become agitated. Well, we stop and ask ourselves, well, if someone was doing that to me, I'd get pretty angry too, and I'd probably kick them. You know, so just being mindful that what are we doing that we take sometimes for granted because we do it every day, and how does that come across for someone that maybe they have dementia, and for them, they don't even remember having to have this done, and all of a sudden someone's, you know, undressing them or otherwise doing something that they're not used to. That can be upsetting, and so we don't want to say fundamentally that's a bad behavior, because that's appropriate in a situation, right? Their behavior is appropriate. What the challenge is that there's a mismatch of context. I'm trying to take care of someone in the nursing home that needs the help. This person's in there. Think about their context. I'm just hanging out here at home and I'm just trying to go to the bathroom. I don't know what's going on. Mismatch, right? So we got to always be communicating and always approaching as if it's the first time. Say, hey, can I help you with the bathroom now? Can I help you with, you know? And sometimes we're exhausted. Sometimes that can be really hard to do. It's like, oh, I got to explain all this. But taking the stance that that's just part of how we function won't make it feel as tiring. We want to just, this is how we approach people. And it just takes repetition. So that was a really good piece of feedback. Alona, can we throw up the first polling question, or whoever's actually controlling it? There's lots of factors here. Programming it. So do you feel comfortable managing a behavioral emergency? Go ahead and give me your answer. And then I want a couple of people kind of just jump in, and you can maybe say verbally, or if you have an anecdote of one that you remember that stands out and how you managed it, whether it went well or did not go well, and you feel comfortable sharing that, that would be really helpful for the group. Anyone, please feel free to share. I want at least one anecdote here from the audience. Calm approach is most effective, absolutely. Nice, yeah, so doing behavior rounds every week, so that's great in terms of preventing, identifying those at higher risk, and being able to sort of address them. That's a wonderful point. We should absolutely take that time every week. That can be very appropriate. Casey, were you going to say something? Come on.
All right, I can say something.
Nice. Okay, go ahead.
All right. So this was just a situation that happened actually 2 days ago. We have two residents that really do not get along. One is very cogent, but he's got pulmonary issues that basically render him into a wheelchair. And the other one is full-blown Alzheimer's, more in her later stages, but she's still somewhat effective for ambulation and doing certain things. But anytime she sees this other resident, she just escalates to the point where a couple of weeks ago, she actually went up and hit him and gave him a nice bruise on his arm. So 2 days ago, they were both in the same area, and we saw exactly what was happening. They were headed for each other, and it was like watching two bighorn rams go at it. And it's like, ooh, quickly. We got one person stood in between them, and hand under hand, we got the dementia lady redirected to, hey, let's go get your hair done, and let's maybe put some new nail polish on you. And we just kind of bodyguarded the other gentleman by standing there until she gently was able to be redirected into this other direction, and we got her away from him. And I don't know what it is about him, but I think there's someone in her past that when she sees him, it brings that person to her forefront. Mm-hmm. And I do think it is something from her trauma past. Mm-hmm. She just gets set off with this individual. So we were able to redirect her, and it removed any threat from him. And he was very comfortable with what we did. And obviously she got her nails done, so it was a win-win. But that's what we did, just a gentle redirect, and don't certainly keep eyes on those two who do not get along.
Excellent. And tell us your name.
I'm Becca. I'm over here in Kodiak.
In Kodiak, very cool. Thank you for sharing that. Very relevant. I think that comes up a lot, is people not getting along in a facility, being mismatches with each other in terms of, and you're absolutely right. There's clearly something that's triggering about that person. And you guys did a great job redirecting and giving something positive for that person. So positively reinforcing that redirection rather than using negative reinforcement, not necessarily needing to jump to medication or restrain or raising voices, but something right. Fun like, oh, let's paint nails. That's perfect. Anyone else have even a situation where you were not maybe happy with, or were either way? Any other examples? got time for one more right now. Great. And then the poll came back, 22% said no, 78% said yes to feeling comfortable managing behavioral emergency, which is great. So for that 22%, we want to see if we can address some of those concerns for not being comfortable. One more poll, and then we'll jump in. Are you able to launch that? Great. Not tricking as many people as I was hoping to with this one. I need to be a little more deceiving with my questions. Yeah, the vast majority are saying assess the safety of the environment and those in the immediate area. Absolutely right. For those of you saying take your own pulse, that's also right. I always like to throw out the trick questions. You guys know me at this point. Part of that is for some of those, if we're trained and we feel comfortable, yes, assess the safety of the environment, like really take stock of what's around you and make adjustments as needed. For those of us that get kind of our pulse starts to go up, we feel a little bit of that fight or flight response, the adrenaline starts to pump. We say this actually in the medical setting too, with, in the ICU, take your own pulse. And what that's meaning is we're talking even for 2 seconds, take a couple deep breaths and slow down and really assess. And then you can jump into environmental safety and those things. But it's super important that you approach that person or whoever's having the escalation, not escalated yourself, because whether or not we use our words, that's conveyed in our body language and how we're feeling. So I know for myself, if I'm kind of amped up, if I approach somebody, not going to go the way I want it to go. So I got to kind of take a deep breath. Sometimes I'm running around, so much in clinic that I'm kind of like, I might have an interaction, something stressing me out. But every time before I go to a new patient, I kind of stop, take a deep breath, close my eyes, kind of just got to reset. So just keep that in mind. It's been helpful for me many times. And then here, Micah said, I usually try to help understand the patient's needs and how their unmet need is affecting their behavior. So I've always learned you don't do social work to someone, but with them. In other words, try to give them the feeling of taking an active role, fixing their situation, regardless of level of dementia. Patients will at least know that how they feel, even if they don't know why they're feeling that way. Very well said. That's a great stance to take. That alone will lead you in the right direction almost every single time. So that's great. So managing behavioral emergencies. Did I go the wrong one? Here we go. So just a few slides about, in terms of really talking about specifics. So we want to, part of that environmental assessment is make sure distractions are minimized. There's as little stimulation as possible, because more stimulation is usually not helpful for someone who's feeling escalated or having too much going on, because you want really more for them to feel like they're being focused on and the attention is on them. It might be appropriate if you're in the kind of a common area, you want to remove other patients if you need to. If there's people that know the patient well, that's a judgment call. They may help with de-escalating. So if there's a family member there, so you want to make that decision. But, if there's other people at risk, if someone like that person that's sitting in a wheelchair and is not otherwise going to be able to help themselves, appropriate to kind of protect those people, of course. Make sure, are there environmental hazards, sometimes objects that might be thrown, or so, a lot of times people try to leave and kind of run out. I'm just being aware of that. You want to be able to have mobility yourself. We always say don't sit between the person and the door. You don't want to block an exit. It's actually better if there's only one exit. It's better for you to actually be to the side, so that, because a lot of people, when they're agitated, they just want a way to get out so they can get out. And, you know, some of us may work in facilities with security, some of us may not. Just keep in mind, you know, in most of these of our behavioral health settings, security has special training, I mean, that they're supposed to. But keep in mind too, that's sort of the last resort, because, you know, when a security comes, that does send certain signals. And for a lot of people that may not be calming necessarily. So it's really an absolute last resort to prevent harm, you know, where you think it's imminent. But in my experience, I think in most of everyone here, I bet security is, you know, in terms of during a career, very, very seldom needed. You know, it was more in a setting when, for example, I worked in emergency rooms where there was active, like a methamphetamine substance, you know, situation going on, or a heroin withdrawal. Those are generally the settings with security. When it's not that in a long-term care facility, I'm hoping you've all had this experience, but I find it to be a lot less frequent. And please correct me if you work somewhere where that's not the case. So the patient that's having this escalation and having this threatening behavior, whether to themselves or to others, you know, at that point, it's definitely appropriate to have someone else present so that you're not alone. You should feel safer and feel that you have the team behind you. So it's always helpful to keep that in mind. You may need to call for help. You may need to do something that may be appropriate before you approach the person. Now, of course, you know, and this can be hard because sometimes we think, oh, you know, Grandpa Joe, he's got, you know, the cigarette and ashtray in his hand. That could hurt, you know, like certain things can become weapons. Just keep in mind, I've been very surprised sometimes with people that I thought were less able or older or, you know, had severe Parkinson's, and they've surprised me with how much they can do physically. So never underestimate the person. They can surprise us with what, you know, just what they might reach for and what might happen. And this might be just in a delirious state, not even anything intentional. We want to really focus on verbal de-escalation, you know, as appropriate. If you really know someone well, you've been working with them for years, you know, you can get closer, get to eye level, but keep the distance that makes you feel safe. If you don't feel safe, trust your gut. Then you're probably too close or too at risk. So that's really the right way to go. Let's jump into this other poll before we kind of continue here. What's the best approach to de-escalate? We're talking about specifics here. Yeah. Actually, while you're answering that, Eileen had a good text here. It says, depends on the resident circumstances. Some of them I was more able to redirect and connect with, but there were a couple who were much more challenging, and I knew other staff could be more effective in dealing with them. Awesome. That's exactly right. Not a failure. There's nothing personal involved here. We all have different strengths. That's the best part about working on a team. So call in that help and say, oh yeah, that person's really good at dealing with, like, you know, ex-military folks, because you know, that person was in the military too. Doesn't matter what it is. Ask for help. You don't need to do it yourself. Anyone else want to jump in here in terms of any anecdotes about de-escalation? Anyone else thought of a story they want to share? Don't be shy. We're all friends here. While we're waiting for some answers, come on, people. Nice. Man, no one wants to offer medications to the patient? Man, come on, guys. The good stuff. You know, we got some benzos, we got some antipsychotics. No one likes that? All right. Try to redirect the patient to another topic. And I purposely, again, you know, my questions are, depending on your perspective, my questions suck, but definitely no one right answer. The redirected patient to another topic, remember, that was contextual. If someone has dementia, memory loss, that may be the most appropriate thing to do. If someone's younger and very with it, they might be really pissed off if you try to redirect them. So that's all about context. It may be appropriate. It's just something you want to keep in mind. Yeah, offering medication just made them matter. Fair enough. Yeah, it's especially how you offer it. It can be very challenging. There are cases, of course, where patients will say, "Oh, can I please just have, you know, just give me something," and you know, that might become part of it. But you're absolutely right. Medications is not the focus. We want to, if we can avoid it, My rule of thumb is I try to avoid PRNs as a rule. And so if someone's like needing something as a PRN, then I kind of actually reassess and I make it a standing order, so that helps both the staff. So I don't want my nursing staff, my caregivers to have to kind of be in a situation where they have to assess and kind of that's a complexity, right? Having to figure out if they need it and then, oh, I got to get it again. And so we want to avoid that, but also it avoids overuse and those kind of situations altogether. Listen empathetically, validate their concerns. Absolutely. Again, generally the right answer. You might find yourself in a kind of spinning a little bit, spinning your wheels when, if you're talking again with somebody does not have the wherewithal to accept that validation. So they may just kind of be repeating themselves. And at that point, maybe time to redirect. And getting down to eye level, this is something I used all the time. I mean, sometimes in the hospital, I'm like getting on my knees on like the gross, like linoleum floor in the ED. I mean, sometimes I want to be lower than the patient because that's less threatening. So if a patient's in fear and they're amplifying or escalating because of that, I'll get down or I'll kind of sink lower because I don't want to be intimidating. Like, I mean, look at me. I'm like this humongous, strong dude with humongous muscles. I don't want to upset people. So it's all about context. So if someone's kind of feeling afraid to you, there are ways you can approach them that are less scary, right? And I know everyone on this call knows how to do this probably better than I do. So thank you for answering that, and avoiding medical jargon. Just kind of just talk to them like you're talking to someone at the bus stop. So how do you address family concerns when they are witnessing the emergency? Alona, oh, thanks, Alona. Why don't you, give me a hard question right in the middle of my slides. Thanks, really, really helpful. No, so that's a great question. Sometimes it's appropriate to, separate family. It just depends on what they're, being aware of the dynamic, and like maybe this family member is actually the one that escalates things. And so it's, it's appropriate to have them leave or ask them, hey, can you step out for a minute? But in general, the communication piece is what helps families. And we've studied this even in places like ICUs where someone's like, the family member's watching the person like be resuscitated, in general, it's a traumatic experience for everyone. So communicating, so big time, like tell them what you're doing if you're doing something and explaining it. So calling out all your actions, don't take anything for granted. And then having a debrief after too, because you might be in the middle of emergency, you might not have the opportunity to really say a whole lot. So making sure they get debriefed and they kind of walk through. That's critical to addressing bystanders who are not trained professionals who are there, because for everybody it can be very traumatic. Louis Buddy was a retired chef. When he was acting out, we brought in our bus driver who had been a police officer. Wonderful. There you go. Avoiding prolonged eye contact. These are not situations where you're having like a real heart-to-heart with somebody. So, you want to kind of, again, it's taking that stance of not feeling as threatening. So you don't want to like stare them down. A little bit of eye contact, of course, you want them to know you're listening. Being non-judgmental, respectful, emphasizing that you're just trying to help. Hey, like, what can I do? And really engage them in that conversation of asking them what you can do and what would help them. Just asking questions is usually the right way to go. So it can be tempting when you're having a fear response to yourself to take the driver's seat and do more talking, but ask questions. What's going on and what can we do? Okay, fine. Oh man, you really miss smoking cigarettes. I'm gonna go get you a nicotine gum. I can do that. I can't let you, smoke a cigarette, but I can let you do that. I mean, just coming up with compromises that will go a long way. These are all things, again, some of these, I know when we read them, they feel sort of at times obvious, but I just know from experience, I got to practice this even in the times when it's not an emergency, because that's when it really matters. So just keeping my own cool, not letting my voice go up more. I often will say, hey, let me get you a cup of water. I mean, it seems like, let's sit down, or, tea or whatever, if they have food. Hanger is a real thing. I'm sure many of us know someone that gets hangry, and what I'm referring to is being hungry and getting irritable. So sometimes that can be enough to reset things. Bringing in help, so those trusted relatives, and really just watching out for that directive. Ask questions instead of saying, telling them things. One thing I wanted to highlight here, consistency with staff, environment that's consistent and familiar. Those are all things that really help with patient feel reassured. If you have a team involved, everyone announcing themselves, saying who you are, being very clear, and having someone that's really leading it. That's really and this is for the situation that's really requiring a bigger response. If you have somebody. Here's the last statement, and then we're kind of wrapping up. It should be recognized that many patients with behavioral emergency have experienced significant trauma and abuse during their lives, which may increase the distress experience during physical restraint. So we should try to minimize the distress, clear communication, being sensitive to issues of gender and culture. Keep in mind, if I know now, like if I'm a guy, I have to approach my women residents a lot differently. I mean, it's not right for me to be the one to be aggressive or physically amplifying. It can be extremely upsetting. It can be very traumatizing. So just keep, this is where we want to keep the whole trauma-informed care in mind. If we approach people with this question in our mind of where might this person be coming from? What else could explain this? All of a sudden that behavior is not, to the person who gave me feedback to that point, it's not behavior. It's a normal response to their context and their situation. And 99% of the time, there's a solution to that. And a very small minority of the time, we may need to use restraints or medication. That's for a different discussion, but almost always we'll be able to de-escalate. Alona's stuck in the evaluation link in the chat box, so please make sure to fill out your evaluations. Make sure everyone gets credit and their continuing education credits. This was the last slide here. And again, just building on that, if a medication is offered, keep in mind then it's even more important as someone's if they're being sedated or just getting more sleepy, whatever, to be even more warm and make an environment that feels safe, because they're going to feel like they're losing control, right? And feel like they're more at risk. So we want to make sure they feel very, very safe, and that they don't have to worry, that they can rest, things like that. So that was the slides for today. Thank you guys for joining. I'm hanging out. I'm here if you have questions, if anyone else wants to talk to me directly, anyone who is too shy to talk in front of the group. For next week, remember, everyone, please come prepared to say something. I really appreciate when you guys participate. Those of you who participate today, thank you so much. It really adds a lot to the talk and making me feel like I'm not just making things up and don't feel crazy. So it's all about me, guys. It's all about me. So just any other questions or comments? You guys are welcome to go fill out the evaluation, or please hang back and let me know if you have any questions.
Yes, thank you all for joining today. And if any of you do have questions on previous sessions that you attended and you hadn't received a nursing CE from me, you can email me. I will put my email in chat.
That's ajarman@mpqhf.org.
Thank you. I'm not sure what happened to your camera, Dr. Gomi. Oh, there you go.
Is that closed the whole time?
No, just like the last 10 minutes or 5 minutes.
I must have hit the little thing by accident. That's so funny. Whoops. Really got me with that question there, Lona. Jeez, that wasn't even rehearsed. That was a good
I got
one.
more.
Oh, good. No, it's helpful. I'm trying to avoid just talking and talking and talking.
Yeah.
So Dr. Gomi, I have a quick question for you.
Yes, please.
Policy with Mountain Pacific, and obviously we see national rates of the antipsychotics. It's obviously maybe going up during COVID, but at what point do you use a medication like an antipsychotic? Do you think people just don't understand or not trained, or just a little too hasty to prescribe antipsychotics or give the resident an antipsychotic before they understand what's happening with them, with their situation?
Yeah.
And, you know, and at what point would you, like, could you give an example of when you might actually give an antipsychotic in an
Yeah.
emergency?
As a matter of course, so addressing the latter question first, when I'm using it is when I've got a pretty clear understanding of the patient's situation and diagnosis. And so let's say I'm pretty confident they have neurodegeneration. Let's say it's Alzheimer's, and the path of Alzheimer's, although it's slow and progressive, it has these blips, and that neuropsychiatric treatment or the neuropsychiatric symptoms are standard rather than an exception. And so there may be a few months in there as the brain is breaking down where agitation happens, like nighttime, like all of a sudden jumping again out of bed and like turning on the stove or breaking things, whatever it might be. And that situation, if there is concern for harm, sometimes family is able to redirect, sometimes not. That's when I will put on, again, I don't want to use PRNs. So I actually never use PRNs myself. I will do a standing dose of something like an antipsychotic, like a risperidone, and at the lowest possible dose, and then I reassess. And usually within 1 to 3 months, I can get rid of it. And so it's meant to be temporary, low dose, and standing. So I try not to make any quick changes. I just find when the PRNs are available in some facilities, it's absolutely appropriate to have them. So, but then you know, you're putting the pressure on a lot of other people of like when to use it, how much to use. So I try to really avoid that and just try to provide that baseline standing or daily dose without having to need the PRN. But I think during COVID, we've had such, I mean, it's a systemic issue. We have fewer resources, we have fewer tools to help de-escalate patients, and they're more likely to feel agitated. And so I think we are probably turning more towards it, and that's really nobody's individual fault. It's just, I can't go out for a walk with this person like I normally do. And, you know, now 6 months into it, they're, you know, pulling out their hair. So I think it takes a lot of training, takes a lot of support, and we just need staff to, we need extra support to be able to like do these non-medication interventions.
Yeah, great, thank you. And it seemed like too, when you know, you do all this training and there's such high turnover in the long-term care setting anyway, too, you get folks trained and then you think everything's good to go, and then you know, then they end up leaving, and so you're recycling through new staff, and it just
exactly
really tough situation, definitely, for our nursing home folks.
No, Amanda's comment about indicating that they're like looking for warning signs. So you might use a PRN to help them get to the point of the emergency. That's absolutely true. You know, because PRNs such as like Tylenol, Advil, things like that, those are very appropriate, because if someone has like the start of a headache, the start of something like a chronic pain, that's going to help, you know, calm the situation before it gets out of control. So there are situations absolutely to use PRNs, especially because it helps you use fewer of them, lower dose, and help prevents escalation. And really, it's the antipsychotic issue is really more, what I find is the person's been on it for 5 years in a row and just never reassessed. That's where we're trying to, it's not a failure to use antipsychotics for a month or two. It's what's happened. But, you know, reality is in places where we're practicing, people don't have the option to get reassessed because there's no one there. So, and, you know, if you have a general medical practitioner, there's a lot of very valid nervousness to take it away or change it. And so I'm usually coming in and saying, hey, you know what? You're older now. This has been around. I'm not sure you need this anymore. So we slowly taper off. And some people still do need it, but I found that more often than not, more than half the time, I'm able to get people off over time.
Great, thank you.
And Don's question about certain kind of dementia. No, Alzheimer's is a type of dementia. So what precedes it typically is mild cognitive impairment. So impairment in function that I can measure, like on a MoCA or an MMSC or some kind of one of those one-pagers, or just in any kind of test where you have them count backwards from 7. Maybe they're messing that up. Spell world backwards. You're having them do some kind of test. You can see that they're having an issue they didn't have before, but it's not dementia yet because they can still do their day-to-day stuff. Like they're still paying their bills. So that's typically what precedes. You kind of have nothing that you can notice, testable things that you can notice, I can measure on a paper, but not see in real life, and then functional decline. And that's when it becomes dementia. reduce, mitigate dementias? That's a good question. I get that a lot. Supplements, unfortunately, we just don't have data to support their use, other than the cases, for example, of like thyroid maintenance, if you have hypothyroidism or B12 deficiency, B6 deficiency, vitamin D deficiency, but those, I'm talking about deficiencies where, you test and you're like, oh, okay, you're only eating tea and toast all day and like you have these deficiencies. Now, absent from those, I have lots of patients that some of them spend $300, $400 a month on supplements. And I just tell them, listen, if you have the money and it's not an issue, fine. I don't think you're going to notice a huge impact, but I also will look at the individual. Most of the time it's like, I don't think this is going to hurt. But I'm wary of people. I don't want you to spend too much money on it. I mean, you want to spend 20, 30 bucks a month on something that's like brain health, and you look on the list, it's got a bunch of vitamins, fine. But keep in mind, some of the mega doses can still be harmful for your liver and kidney. We just don't have evidence that shows that it has much of an impact on long-term dementia outcomes. Melty tabs that are essentially useless once he's totally wound up. Yeah. I love that you call it a melty tab, Amanda. Is that what the pharmacy calls it? Agitated is, I know, I'm kidding. So process, rationalize. Melty tabs, someone who's getting agitated. Yeah. So you want to do it before they get, absolutely. I mean, as kids especially, they have such high metabolism, and like you can't predict how medications are going to work. So it's just so challenging giving medications to kids because sometimes it doesn't do anything. So and you're right. And once they're wound up, so try to intervene before that. Any other questions or comments?
There was one question that Don had posed in there. Is there a certain kind of dementia that precedes Alzheimer's?
I already answered that one. Can you pay attention, please?
You did. Oh, sorry.
You're busy answering everyone else's questions.
I'm trying to think of ones to stump you.
No, I appreciate it. And people know how to can reach me too. That's a good question.
Feel free to come off mute too if you guys have additional questions. Take this time with Dr. Gomi. Obviously, he's very knowledgeable. I asked about the supplements just because I think about the impacts of COVID and long-term effects. And I'm even hearing long haulers such as myself. And still, my kids joked with me this last weekend. They thought I was starting to get early onset dementia because we had went out to eat. I'm like, where did we go? I don't remember. It was very odd. It was just like, I couldn't even recall the night before. So I'm like, yep. Hopefully that comes back.
I'll come back. Cool. Okay, well, I will see everyone in a couple of weeks then.
Great. Thank you, everybody, for joining us today. Have a great rest of your day, evening, morning, wherever you are.
Thank you.
Thank you all. Thank you so much. Bring some comments for next time too.